the O'Brien Institute for Public Health and Department of Community Health Sciences for this webinar titled Community-Based Participatory Research in Harm Reduction, Lessons Learned, and Thinking Ahead. For those of us who are joining from Calgary, I would like to take this opportunity to acknowledge the traditional territories of the people of the Treaty 7 region in Southern Alberta, which includes the Blackfoot Confederacy comprising the Siksika, Piikani, and Kainai First Nations, as well as the Tsuut'ina First Nation and the Stoney Nakoda, including the Chiniki, Bearspaw, and Wesley First Nations. The city of Calgary is also home to Métis Nation of Alberta Region 3. Today, we're joined by two presenters, Dr. Lara Nixon and Dr. Martina Kelly. Dr. Lara Nixon is an academic family physician and associate professor working in outreach team-based inner city care with older adults with experiences of homelessness. She's an O'Brien member, and her research focuses on health equity and integrated health and social service innovations. This work involves close collaboration with community partners, including service users and providers. Our second speaker, Dr. Martina Kelly, is a family physician working in Sheldon-Shumere, where she cares for a diverse population. She is a professor in family medicine with a joint appointment in community health sciences. Academically, she guides undergraduate family medicine teaching in the Cummings School of Medicine, and her research spans medical education and mental health with a generalist lens. I now turn it over to Dr. Nixon and Dr. Kelly to begin your presentation.
Thanks so much, Chantel. And I'll just get our slides started. And thank you very much to the O'Brien Institute and the Brenda Stafford Center on Aging for the opportunity to speak with you today. We're really grateful to be here. We don't have any conflicts to disclose and have done our best with following copyright requirements. And we're here to speak with you about work that is the hands of many. It's the result of many people's efforts. And this includes our study team and our research staff, as well as a number of students and our community advisory group and community partners from Peter Coyle Place, as well as external collaborators and some expert advice that we received very early in this project. And so we're here to talk with you about harm reduction housing for older people with experiences of homelessness. Our hope is to share with you some of our successes and challenges in conducting community-based research with older people in this harm reduction setting, particularly during a pandemic, and relate these lessons to the current context within O'Brien and more broadly. And we're really looking to you for some guidance as well as far as future opportunities within institutional structures that might help to support this type of research. So just to give you a little bit of a sense of where we're hoping to go today, we'd like to give you some background, both from the literature as well as our own work in prior studies. And then we're going to zoom into our recent work on the ground. We'll then zoom out a wee bit into the big world to take a look at what's been happening that has had quite an influence on our work on the ground, and then look at the in-between and what we're calling the messy middle. And hopefully our take-homes will have some use to you in your work and in potential future projects. So to start, we wanted to share with you some local data that we have from the Calgary Drop-In Center, Calgary's largest shelter, that looks back at the rates of homelessness amongst older people in a 15-year period from 2001 to 2016. And you can see this is a more than 360% increase, really quite significant. And this only captures people who are visibly homeless. Doesn't capture people who are sleeping rough, who might be couch surfing with friends or family, or who are in unsustainable rental situations like hostels or motels, or in our institutions, penal or health institutions, sometimes for days, months, even years, awaiting an appropriate community setting to return to. These individuals are experiencing really complex health challenges because of the effects of being street affected and the deprivation associated with that. Age 50 is considered old for people who are street affected. And this is related primarily to the early onset of geriatric conditions, things like urinary incontinence, poor balance, frailty, memory concerns. And then there's a whole host of complex chronic physical and mental health challenges that people experience. These conditions, as listed here, come from local work by Dr. Katrina Mullaney and her team, where 147 people over 50 were surveyed about their health conditions and experiences in the shelter system and other systems. And so these make it very challenging for these folks to navigate homeless serving systems and for us as health systems to respond to their needs. Our aged care systems are really not very well suited to meeting people's needs because they use an arbitrary age of 65, like many benefits in Canada, of the age of access. And you need a fixed address to qualify for many of the services and benefits that are intended for older people. Abstinence from substance use, except that which is explicitly sanctioned, is required. And homelessness policy is also very oriented to younger people. A policy review in 2015 by Barkin and Grenier's group at McGill looked at 42 municipal, provincial, and federal documents, as well as territorial, and only 4 of them made any significant mention of older people's needs, and 3 of those were out of Quebec. The 4th was in BC. So there's really quite a basically null policy when it comes to older people experiencing homelessness. And colonialism and racism have been identified as actively contributing to the ongoing and overrepresentation of Indigenous older adults who are visibly homeless. They experience a 20 times increased risk compared to non-Indigenous people of being in shelters. So this service gap and knowledge gaps have been acknowledged in Canada's National Housing Strategy in 2017. And funding through CAMH and CMHC and SHRC has been secured by a group led out of Simon Fraser University called Aging in the Right Place, whose intent is to explore and evaluate promising practices in the care and housing of older adults experiencing homelessness, to increase research capacity and to promote positive policy and practice change. And our work is contributing to this project's efforts. So we'd like to just give you a little bit of background of the specific local setting where our work is based now. And Peter Coyle Place is a 68-bed facility for specifically targeting the needs of older people with experiences of homelessness. It was established in 2005, and although they started out with the intent to be transitional housing, and that's how they were funded, they quickly realized that there was not very many places to transition people to, and they started offering low barrier housing first type of permanent supportive housing. They embrace a harm reduction philosophy and have done so since opening their doors. And it's a unique setting because most housing first approaches emphasize scattered site individual units, whereas this is a congregate building. The supports on site are available 24 hours, 7 days a week, and full meal service and housekeeping is provided. On-site social workers are there to support people. Visiting home care providers, a home care nurse who is very dedicated, has been part of their team for many, many years. And there are other visiting health providers, primary care, assertive community treatment team, psychiatry, for those who qualify and are part of that program. And so we had the good fortune, myself and Dr. Victoria Burns, who was a postdoctoral scholar from McGill and is now faculty in the Faculty of Social Work. We had the opportunity with O'Brien Catalyst funding and a seed grant from the Department of Family Medicine to do a qualitative study looking at the experiences of staff and the people living at Peter Coyle Place in terms of the harm reduction policy and how that impacted their work and living experiences. And we were very fortunate to learn about how harm reduction policy helps staff to express respect and earn the trust of these older individuals, many of whom have come in with some pretty rotten experiences in our various systems in the past. And that proximity that the trust allowed helped them to identify and develop individualized supports that then helped to share the responsibility with the residents themselves for reducing harm related to substance use. The residents told us that they felt respected by staff and a sense of belonging, and they trusted staff and were more willing to accept help that was co-negotiated. Unfortunately, we also identified a number of structural constraints that tied back to, as I mentioned before, their level of funding, which was, has not changed since they opened their doors. And with that, a lot of stress on staff and associated turnover related to their resourcing. And in some cases, particularly amongst some visiting agency staff, a lot of unfamiliarity and discomfort with harm reduction approaches, giving alcohol to people with alcohol dependence, for example, in the managed alcohol programming. Lack of space is another challenge to meeting the needs of this really relational work. There's very little private space to have one-on-one visits with people or to do other activities. And being a single site in Calgary puts a lot of pressure on this, this group to accept more and more complex and acute needs people as our numbers of older people experiencing homelessness increases. So with community partners and lots of expert guidance from our own department and people within O'Brien, we identified the opportunity to add some resources and build some new partnerships and endeavor to improve the sustainability and the robustness of this programming. And we were able to secure quite a significant pot of funds from Health Canada to do this work. And we felt pretty chuffed about that. And the protocol we put together, we were really pleased, was acknowledged with some really generous feedback from the Research Ethics Board. And we felt really, really ready to go on this work when we started. And so we had identified this pressing community problem, felt that a community-based participatory research approach was the path to move forward on and reach our goal of improved health and social outcomes for people, healthier, happier staff, more partnerships, and a sustained model. Rainbows and unicorns, that's what we were hoping for. And this work that we're speaking to specifically is looking at the staff experience, the residents' experience, and the co-design of the intervention. It's part of our broader project, which includes some other work as shown here that we won't be speaking to today, just to orient you. So we want to speak with you about our experiences on the ground. So I'm sorry, that's a long-winded background, I suspect it might feel like, but we wanted to be sure we were being clear about where we've come from and where we thought we were going, because our journey has been a little bit, well, not all rainbows and unicorns. So starting with on the ground, we have a remarkable team of women that we're working together with, right, boots on the ground. And our team started with town hall meetings prior to our REB application to inform that. And from those meetings, identified some individuals in the community at Peter Coyle who were keen to form an advisory group. And we have met with them almost 20 times since September 2019. And they identify as the exchange. And together we've been working on a number of initiatives. And this is them pictured here in the foreground. And we've been really, really grateful for their input on the intervention launch itself. So we applied specifically based on our prior work for funding to support addiction and mental health nursing, formal recreation programming, and over our discussions and from the nursing and rec programming's input and other staff and residents' input, we identified the benefits of bringing on a peer support worker. So that's been really powerful for us. Forgive me, I'm just going to pause here. But as we alluded to before, it's not been all rainbows and unicorns. And in fact, we learned from our community discussions that there were some issues with group and power dynamics. And I just want to share with you here a couple of video clips that will give you a sense of their feedback to us, which we really took to heart. What the heck?
You might have seen
Okay, I'm so sorry. I have messed something up here. There we go. Oh my goodness gracious.
So tricky when you have like residents and staff in the same group, how to troubleshoot so that it doesn't feel like one group is stepping over the other group.
Mm-hmm. Maybe they do have something to say, but they might censor themselves because staff is there, or they might see it as an opportunity to, I don't know, maybe corner staff.
So our staff advisors pointed out some of those difficult sort of power dynamics between themselves and residents that they identified as potentially concerning. And then our resident advisors helped us to see some things that we did not appreciate the importance of, but had a lot of impact on their comfort in participating.
Even just calling Dr. Nixon, Dr. Nixon, I mean, you know, it should have been down another level from there. Allison shouldn't have been representative of building manager Allison, because I feel that what that did, and I said this at the beginning, I feel that what that did was set up little camps where, okay, we're Allison's people, okay, we're Dr. Nixon's people.
So, forgive me, I'm just going to go back to here. So when we identified these power dynamics that were interfering with our partnership with the group, it was really, really powerful and helpful. Simply changing the way in which we referred to one another within our team made a really big difference. And we noticed a very significant turning point in July of 2020. So about 10 months into our work together, where suddenly people were more confident and comfortable speaking frankly, including about addiction. And the exchange identified an output that they wanted to develop together, which was what they called a wallet-sized definition of addiction. And that was intended to spark conversation and hopefully develop a broader understanding and appreciation of what it's like to have addiction. And in doing this work together, they identified ways to invite really broad community input. And what I've displayed here is comments from staff and residents themselves on the bulletin board that we've set up, which, as you can see, displays a whole bunch of different stuff, including naloxone kits and condoms and safe disposal containers. And we were really proud of this work with them, and it's ongoing to develop this wallet-sized definition of addiction, which together we have been discussing conceptualizations of addiction from the literature and layering in their experience and perceptions. So on the ground, we've been doing this lots of work with the community and feeling really quite excited and appreciative of the privilege of meeting with them and getting their explicit guidance. And I think it's really helped us to develop our interventions in a way that has meaning to the community and will be beneficial in future. We'd like to just zoom out into the big world for a moment, because lots has happened out there, as I think you probably appreciate, that has had impact on us on the ground. So starting at the top here with that little thing called COVID, we discovered that public health emergency requirements for infection prevention and control do not mesh well with harm reduction approaches. The monitoring, the tracking of people's movements, and the restriction of people's mobility has been in complete contradiction to virtually everything that is normal practice in this building. And although there have not been any deaths, despite us having one very significant outbreak just in September, October, there has been a really significant sense of loss for the community, primarily related to this freedom and changes in our operations, and also a lot of fatigue. We're really grateful for some incredible supports that we have received from our local acute and community partners, acute care and community partners that we'll speak to in just a moment. And so that's been a real positive, but closures at other levels, like within the university, that have really impacted our team's operations together and how we can collect data and meet with our community partners, as well as closures within the city of really important support programs that our community members relied on and benefited from in terms of their quality of life. At the Alberta level and the federal level, political landscapes have had quite an influence on us on the ground as well. The defunding of harm reduction initiatives and the threat to further changes in that regard have weighed heavily on us as researchers and frontline workers, as well as the community of residents themselves. We've had many a discussion about that. Because our work has really, the timelines for our work have been really affected by closures of the building and other disruptions to our meeting and data collection. We applied to Health Canada for an extension on the project, and despite anticipating knowing about that in August, the federal election announcement and subsequently the changing of the ministers have delayed that announcement for us, which has put us under a lot of pressure and fear that we're going to lose critical staff who are well known and trusted to the community. And so these big wide world sort of forces have had a lot of influence on us and our work on the ground level with our community. I now want to move into what we refer to as the messy middle, because our community partners have been experiencing the same big world challenges as we have been on the ground. Firefighting and responding to COVID, developing protocols. Some partners have had expansion projects that had been in the works for years, and so there's additional competing demands. In some cases, there's been major leadership and staffing changes, redeployment of staff, staff turnover, and all of this has required us as researchers to be highly adaptable and flexible and forge many new relationships and invest a lot of time in helping new partners and stakeholders understand where we've come from and why we're doing and trying to do what we are doing, and really renegotiate our project expectations and expectations of one another. And so that's why we call this our messy middle. We're super grateful, as I mentioned, to many new partnerships and supports, especially in light of COVID. And I'll share some of the specifics of that in a moment. So we'd like to just sort of highlight here that our experiences on the ground and from the messy middle in the context of the big world, that being alert to power is really important. And of course, CBPAR processes and principles draw our attention to that. But we came into this work having a long-standing relationship with the community already, but it was in a different capacity. And so that's our number one lesson for ourselves and suggestion for yourselves. Next one is that life happens. Now, maybe pandemics don't happen every day, but political changes happen, priorities change, and that flexibility and responsiveness is something that is really really valuable to kind of keep an eye on and be prepared for. Our third is that CBPAR is a bit like renovating. Plan on twice the time and double the resources that you thought you might need in order to do the work as it emerges and that you would like to be doing. And I think our middle one here, relationship first, task work second, is really our central message. This work is completely grounded in partnerships and collaboration. The whole point of going into the community is to ensure that the community's voice is loud and clear, and that we are the go-betweens between the literature, between institutions, and we need to really be attentive and constantly not only monitoring but investing in those relationships. And that has led us to reflect on the maturity of our relationships in this work. We thought we had a fairly established relationship coming into this particular phase of work. And in fact, just a few forces, some of them in the big world and some of them more in the messy middle, had a lot of impact on the security of our relationships. And we had to invest a lot in reestablishing and renegotiating. And we have been super fortunate in being able to phone a friend, and in fact, sometimes many friends, when we felt snowed under. And so this is not work for the faint of heart or for lone rangers. Allow yourself to ask for help, and it's an amazing experience. Just a few of the folks we'd like to thank, and I fear this list is far from complete, but I did want to highlight and share with you just some of the range of departments and individuals that have really stepped up to keep us going, both operationally and in terms of our project. And we really welcome your questions at this stage. And while you're perhaps hopefully thinking of one or two, we'd like to invite your feedback on how can we progress this type of work and the critical relationships needed to do this work in the context of current funding structures.
Thank you, Laura and Martina, for your presentation. We do have time for question and answers now. So if you haven't put your questions in the Q&A box, please do so. To kick us off, I'll just ask one to start. You talked about being alert to power as one of your take-home messages. Can you discuss some of the specific strategies you use to address those imbalances, or what you would recommend that others think about?
Thanks for that question, Chantel. It is something that we have talked quite a bit about. And we came in with some excellent recommendations from Dr. Stacy Page and Dr. Pamela Roach. One of the strategies we used to provide lots of opportunity for people to participate in whatever capacity they felt comfortable with. I mentioned town halls that we had early on as well as ongoing. So not data generating, no consents needed, just very informal table chats in some cases, or just pull up a chair and circle chats with the community, whoever was there, whoever showed up. In the exchange, we certainly did away with titles and made sure everybody was appreciative of that. We also identified with the group that some people felt more comfortable sharing their ideas in written form or asynchronously. And so some exchange members actually make time and space to confer with other members outside of the meetings to elicit their ideas. Everybody received a notebook. That was one of their suggestions. We made sure that everybody got a notebook that they could record their ideas and just tear out the page and pass it to somebody or give it to us later. And others, members and broader community members identified that staff were who they wanted to share their ideas and concerns with. And so our on-the-ground operations have been really fluid. And then another piece that might be helpful to this group, and I can provide the references subsequently, is using something called process consent. So as opposed to traditional approaches to consenting people for data generation purposes, where a big long form is read and consent is done at the front and then you're done, never looking back at that. Every time we're looking for people's input, our team on the ground goes through a brief reorientation, reminding people of who they are and what we're there for and what we'd like to discuss. And if there is any sign of a person not feeling up for that or feeling uncomfortable, we simply step back and re-engage at another time with their permission. Because our hope is to be as inclusive as possible, but be certain that no one feels coerced into contributing. And so that's the whole notion of process consent. And Dr. Pamela Roach was really instrumental in us learning about that approach. It comes from largely from research with people with dementia. And it ensures that we are not excluding people who might temporarily lack capacity due to mental health conditions, physical health conditions, substance use, any number of things.
Thank you for that. A lot of learnings came out of that. Along similar lines, and you probably addressed this, one of the questions are, could you share how you address differences in power dynamics in practices on the ground? And then the second part of that is about assumptions of the study itself. So maybe were there any assumptions that you had made about power dynamics within the study?
Yeah, that's an excellent question. Do you want to speak to that, Martina? We came into this work kind of concerned that, oh, will we get community input? Will the people living there be interested? Will they have the energy or the resources to participate? And heck, they've been so present and so engaged. That video clip that we showed was part of a formal presentation to the Alberta SPORE unit conference last year, and we just did another international conference presentation. It was a workshop on the ethics of participatory research. We've had really great response to surveys that, we didn't mention this part of our work, but the exchange identified the food offerings and dining experience as a real area of concern within our work together and impacting quality of life. Well, they launched a food survey and they got great response and participation. And so I think that was one of our assumptions going in that really has been a wonderful surprise. And I think we assumed, like I kind of alluded to, that our partnership with our main organizations, our relationships there were more mature and robust and could withstand kind of ups and downs. And in fact, they've been quite challenged and needed considerably, in hindsight, considerably greater resourcing than we anticipated. And that's largely due to changes in leadership and turnover in staff and all of these competing demands on not-for-profit organizations' limited resources already. So if we had something to do differently going forward or going back in time, we would have sought guidance from much more expert people in O'Brien about how could we ensure that the resources are within the agency and we can rally those to be the active partners that we were hoping to be. So that's a work in progress.
We have another comment. Fascinating and excellent work. They would like to know, did Health Canada deny your extension request?
They have not. They, unfortunately, all of their decision making, when the federal election announcement was made, everything stopped. And so August 31st came and went, and we were told, well, decisions will be made in the new year once the new government comes in. And unfortunately, the new government has come in and there's still no decision in sight because 2 ministers have changed. And so our work is currently officially going to end in August. And that's really cutting our timelines much shorter than we'd hoped for. Our application is for to extend the intervention and our research until March, the end of the fiscal year in March 2023.
How did you implement harm reduction education for staff who are not comfortable with the principles?
That's an excellent question. And a number of initiatives have been undertaken, some very small scale, more one-on-one, particularly by the addiction and mental health oriented RN. There have been lunchtime discussions facilitated by her along with myself and some external experts like SafeWorks, using films as triggering discussions, as well as some case discussions. There has been some implementation of structured debriefing time and more formal team meetings, setting aside a reliable time where everybody in different sort of subgroups actually identifies successes and challenges. That's gone a long ways, I would say, to increasing people's comfort and a bit of consistency in how we think of harm reduction.
And I think we interviewed a lot of the staff at the beginning and throughout the project. So I think exploring their own ideas, concerns, expectations around harm reduction helped us identify, I guess, a spectrum of where people were coming into buying into the idea. And I think we've been able to feed that back to the staff. And then we're hosting a staff retreat next week where we'll try and bring some of the more dichotomous views and then generate some conversations around them. And actually, I think the residents have been very powerful too, in
Mhm.
terms of, initially, I think there was again a diversity of acceptance
Mhm.
to the idea that Peter Coyle Place delivers harm reduction. But through the work of the exchange, through the interviews, through all the conversations that have been going on, it's interesting that the residents, who were often some of the most vociferous people, who were like, this is ridiculous, we need to have more discipline in this place, this is terrible, they are people who are actually now asking the staff
Yeah.
for harm reduction training. And I think that's actually really changing staff attitudes, because
Yeah.
staff are very, very committed to the residents there.
Yes, they've become amazing ambassadors
Yeah.
for the philosophy, basically.
Are you able to share some of the reasons why staff said that they were uncomfortable with these principles? What were their preconceived notions or attitudes towards it?
Well, I think, first of all, although the staff were, when they were hired, they were sort of aware that it was a harm reduction facility. But when you actually ask some of them, well, what does that mean? They didn't really have any concept whatsoever. For some staff, it was quite shocking that people with alcohol use would be given more alcohol. And it was quite distressing for them, in particular, when they would see somebody maybe continue to drink, for example, and then harm themselves in some way, or maybe experience a fall or a head injury. So that, I think it was sort of knowing it on one hand, what harm reduction is, but then actually seeing somebody continue to perhaps harm themselves and trying to respect that space. That's a difficult thing, I think, if you're trained in a caring sort of role. So I think that was a challenging piece in particular for them. Do you want to add anything?
Yeah, I think the staff diversity is very similar to the diversity of the people living there. And I think creating space for people to feel comfortable voicing their perspectives and actually listening to one another and learning from those. It is, in addition to diversity, the array of expertise that the staff bring and develop is really, really remarkable. And so I think diversity is the rule in this place. And so the more we suspend our assumptions and judgment, not only of the people living there, but of each other, and facilitating development of understanding and respect and trust amongst the team is a really, really powerful potential force. That's what we're trying to do. But that has been really challenged by the degree of turnover and the competing demands of expansion within the organization to other sites, and COVID itself and all the demands and disruption related to that.
So you touched on specific strategies you use to implement to educate staff, and along what you had just said, more broadly in the healthcare system, how can we educate and train healthcare providers in creating safe and inclusive spaces for people who are homeless?
Well, that's what we hope to do if we get the extension. But I think one thing we've been thinking about is the idea that often as healthcare providers, we are trained towards a sort of model of cure or getting people better, or goal setting. And that one of the challenges sometimes for people who have hard lives or histories where they've been not always treated right by the system is that their stories don't always have that sort of linear model. So goal setting, for example, is not always the end all and be all of everything for people who are just trying to get through another day. So we have drawn on Arthur Frank's work using the chaos narrative as a potential way to look at how we listen to people's stories, and how instead of trying to go along what we call the restitution narrative of, you know, cure and being heroes and all that sort of stuff, is actually just to pause, listen to people properly, acknowledge their stories as essential to trying to help us as healthcare providers reorientate our inner stories and our narratives of what harm reduction can be. And so that's one sort of strategy that we're thinking about. We haven't done anything with it yet. We're sort of thinking about it, but that's one thought that's going through our team at the moment.
And I think also encouraging us all to think about our own situatedness and the opportunities through those expressions of respect and earned proximity. That's how we get a sense of where a person is and what might be helpful, not to simply change their behavior, but change the environment in which we're all working and living in, such that fewer harms are experienced by people who are perhaps engaging in high-risk behaviors, but suffer the harms because of the environment in which they're in. And so we all engage in high-risk behavior every day, but we benefit from environments oftentimes that are set up to reduce the risks of harm. Safety railings on highways, seatbelts in our cars. These are all strategies in the environment that help us to experience less harm as a result of our own high-risk behaviors. But the folks that we're working with have suffered excessive harms as a result of very similar high-risk behaviors. And they do so because of the social, political, economic, and physical environments that we make available to them and or exclude them from. And so there's a big opportunity, and this comes from ecological public health, risk environment frameworks. Tim Rhodes' work from the International Journal of Drug Policy just reveals what can happen when we move beyond individuation of risk and rely solely on individuals. Are you ready to make a change? Oh, okay, you're not. My work is done here. And instead, we look at, rallying the fighter jets so we can, oh, well, what if we simply had a visit every hour or so and checked in to make sure that that person is okay? What if we actually made safer substance use supplies readily available? We didn't require that people go to a distribution site that was 4 bus rides away, right? We actually bring them to them. We know that substance use is happening. So let's help people to be as safe as they can be. Those would be some of the strategies.
That's great. Our next question is, have any particular theories, models, or frameworks been helpful related to harm reduction, community-based participatory research, evaluation, or implementation? And if so, how did they help?
Go ahead. Some we've just mentioned, the risk environment framework, but by Tim Rhodes. It's a simple heuristic that looks at different levels of context, much like we've spoken to today, and examines how those physical structures, social structures, political and economic structures interact to increase the chances of harm or enable positive change and reduced harm. That's been a guiding framework for our work for quite some time.
We looked at resource demand model when we were looking at staff experiences because we were concerned about burnout, and it worked, but not to a certain extent because it didn't really, I think it sort of underestimated the sense of dedication and passion that people get back from working. Like the staff in this setting, they're just so dedicated and they get a lot back out. So the resources were quite high at the beginning of COVID. things have changed, but so that's a framework we looked at, but we decided not to use it in the end of the day, and we've then started to look at some narrative approaches to looking at operationalizing harm reduction education. Yeah, and then we've looked at Plandinen's model for 3D space, looking at story making, again, because the residents and the staff have identified that particular incidents are often, it's the stories that stay with them. And so then looking at how we analyze stories to restory has been a useful, that's a lens that we're looking at as well. That helps.
And that ties into the next question about any guidance on how best to evaluate harm reduction or trauma-informed services beyond numbers. So thinking of the qualitative data.
So we are using narrative approaches to look at the residents' stories, because when we interview the residents, I would say that their data is not rich in terms of being highly descriptive and in-depth, but it's very rich in what it doesn't say. And so trying to be very attentive to things like plot, to timeline, to how these disjointed stories, like sometimes in an interview, a story could start at the beginning of someone's life, then suddenly you realize they've had 3 children and be divorced, then they're living this sort of presented as normal life, but suddenly they're in the park buying crack at the age of 74. And so trying to map out those stories, looking at these different disjunctures, has actually been quite helpful. And in terms of even then telling the story back to the person about how we have perhaps interpreted their life, and their stories are impacted by our stories and our experiences too. And that's been quite I think that's been a nice I think that's been helpful for the residents to re-identify who they are, that they're not like in the addiction slide that we put up, that they've had trauma, that addiction is about sorrow and loss. And so giving the residents back an opportunity to acknowledge that has been, I think, a benefit of the work.
And I would say structurally, we've been doing interviews in the field over time, longitudinal qualitative interviews, and seen over the series, as oftentimes is the case, as our team and project gets better known, there's more and more comfort, I think, to share experiences, and we're learning together with the community how to do this work and how to explore it. And that really has to be with qualitative methods. Our study is a mixed method study, qual-quant in its setup. So.
And I think we have time for one final question. Is there more harm caused by asking participants about experiences with these services using evaluative questions?
We've asked them about service use.
We do have a survey, a resident outcome evaluation survey that we co-designed with the community. And the focus is on people's perceived need for services and whether or not they're accessing services, and invite them to share with us what barriers they may or may not have experienced in so doing. And the surveys themselves are done in person with the same team that is doing the qualitative work. And so,
I mean, that's a good question. We can go back and ask them in
Absolutely.
the exchange. We will take that as a question to explore, I think.
We get the impression that people are quite happy to do the surveys. They seem to be very engaged in them. They tend to be quite rich conversations, actually. And so, but yes, it's an excellent point, and happy to be continued.
So there's no final questions in the Q&A. I would like to thank you both again for your wonderful presentation and everyone who was able to join us. If there are any other questions that come in, we'll share them with Lara and Martina to answer following the seminar. But that concludes today's seminar, and I hope everyone has a great day.
Thank you so much for the opportunity to speak with you today. Our references, many of our citations are posted. If anyone has interest, please don't hesitate to reach out to us or snoop around our website. We'd love to hear from you. Thanks so much.